Welcome to Module 1, Surgery in General Practice. I am a board-certified veterinary surgeon, small animals only. I grew up here in New York City and I worked a lot with horses, but decided that dogs and cats were where my passion lay. I did my veterinary training at University of Pennsylvania and my internship and residency at the Animal Medical Center. Now I focus on all types of surgery, soft tissue, orthopedics, and minimally invasive surgery. My particular passion, however, is teaching. I love teaching hands-on in the clinic, and I love teaching as well to you here in this format. In this module, we'll talk about some of the most commonly performed procedures in general practice. We'll give you some tips, some tricks, and also talk about a few cases. The first procedure we'll cover is a cystotomy. Most importantly, you're going to want to take some x-rays beforehand, plus or minus an ultrasound if those stones are radio-opaque or radiolucent. When you're ready to do your cystotomy, make a caudal abdominal incision just big enough to exteriorize the bladder. Exteriorize the bladder, pack it off with laparotomy sponges, and place stay sutures in the apex of the bladder. I usually choose 4/0 PDS on a taper needle to make the smallest possible hole. Then you'll make your ventral stab incision. I usually use a 15 blade, again making this hole just large enough to get your stones out, fit a bladder spoon in, and sometimes feel with a very small finger. Use your bladder spoon to take out as many of those stones as you can easily see and feel, making sure not to forget both the trigone and the apex of the bladder, and then flush. Once you think you have all the stones out, usually there's still some left behind. So using a red rubber catheter to flush the urethra, both antegrade and retrograde, is really important to try and flush those stones back up into the bladder and out of the urethra. Once you've done that and you still have your catheter in place, if possible, take another feel, try and get more of those stones out. I'll also flush the bladder itself. Sometimes I'll use that bulb syringe and just flush the bladder directly to get any debris or any really tiny stones out of there. When it's time to close, I like to leave that catheter in if it's a male dog or cat, and then close again with your 4/0 PDS, the smallest suture you possibly can find, with a taper needle, and then I prefer to use an interrupted suture pattern. Once you've been doing surgery for 40 years, you can do whatever you want. You can do continuous, but I prefer to have that security of an interrupted suture pattern. You can use whatever other monofilament absorbable suture material you choose. Just make sure it's a small tapered needle of a 3/0 or a 4/0 size. Then leak testing. Whether or not you have that catheter in place, place your hand at the trigone and include the outflow to the bladder so you can maintain some pressure inside the bladder. Create that pressure and evaluate your site for any leaks. The most important last step of a cystotomy isn't surgical at all. It's taking another set of x-rays after surgery. A study has shown that up to 32% of patients with cystotomy may have stones left behind, so it's incredibly important to take those x-rays and make sure you've gotten all of them out. Another incredibly common procedure that you'll need to do in general practice is surgery for a pyometra. How do pyometra cases present? It's very common. About 23% of middle-aged to older intact females will undergo a pyometra or a uterine infection if they remain unspayed. It happens while they're in diestrus, usually about 2 or more weeks after their last heat, but very frequently owners don't exactly know when that was. So things to watch out for. Discharge, that's an open pyometra. Not every pyometra will have discharge. Some closed pyometras may present without that obvious sign. What you will see are polyuria and polydipsia, vomiting, lethargy, anorexia, dehydration, and elevated temperature, as well as you can see on your blood tests hypoglycemia, neutrophilia, or even a neutropenia if they're very, very ill. Immediate treatment once you've diagnosed a pyometra should be IV fluids and antibiotics, and do not perform a cystocentesis. You'd be surprised the number of times that there's some confusion about whether some of these loops are bladder or uterus, and you could contaminate the abdomen. Important things to talk about with an owner of a patient with pyometra is that, first of all, the prognosis is usually very good. About 92% of dogs and cats with a pyometra will have a very good prognosis, but there are risks. So you do have to talk to them about the potential for sepsis, of a septic abdomen if that pyometra has ruptured, but also there can be translocation and sepsis even without rupture. There can be renal failure. The E. coli in a pyometra has an endotoxin which can affect the kidneys and cause renal failure. They can also have anemia and urinary tract infections. Other things for expectations for owners. I was taught that you never let a sun set on a pyometra. That certainly is the case for a closed pyometra or a patient who's very ill. But if it's been chronic, the patient is very stable on blood work and physical exam, and it's an open pyometra, if it's late at night, it might be the kind of thing you can let wait until the morning on IV fluids and antibiotics. I won't go into too much detail about how you treat a pyometra because it is a spay. But a spay is not just a spay if the uterine horns are very, very full of all of that infected material. You have to be quite careful with handling of a pyometra during the spay. Other things you might want to keep in mind are when ligating the uterine pedicle, some surgeons prefer to only use one ligature. And if you do that one ligature in order to avoid trapping any bacteria between two ligatures, you better be darn sure that that is a really, really good, tight seal. I usually prefer to do a modified Miller knot, and sometimes I will individually ligate the uterine vessels on either side if I want to make sure that bleeding isn't a risk. Dystocias are one of those things that we used not to see quite as often, but now with the popularity of those really cute brachycephalic breeds, we're seeing dystocias more and more. The different causes of dystocia can include maternal causes like uterine inertia. They can also be breed or anatomic like brachycephalic dogs. Also, pelvic fractures can prevent puppies or kittens from coming out normally. Fetal causes for dystocia can include malpresentation, not that common because breech dogs and cats can come out pretty normally. Oversized or single puppies or kittens, quite common. Fetal death and fetal malformation, relatively low risk. The most common reasons that we see are fetal maternal disproportion. So very large fetuses or ones with really cute big heads that just can't fit normally. Not every pregnant dog or cat brought into your clinic with an owner who's worried about a dystocia truly needs surgery. So what are the true signs of dystocia? Certainly toxicity in the dam. Any signs that she is systemically ill. A lack of progression from stage 1 to stage 2 labor in 12 to 24 hours. Failure to deliver puppies within 36 hours of the maternal temperature dropping below 100 degrees. You might not know that. Unless it's a breeder, you probably won't have that answer. Most commonly, we'll see active straining for greater than 30 minutes or weak straining, sometimes for several hours, but greater than 2 hours is when we should be worried. 4 hours since the last puppy would certainly be another reason for concern, or prolonged gestation, abnormal discharge from the vulva, or a retained puppy that you know and see is in there. Now, cats can take much longer between kittens, so the time between kittens should not be used as a cause for dystocia. Since, of course, we want to do everything possible to prevent surgery, there are some non-surgical or medical treatments for dystocia that you may want to try first. Certainly, checking the calcium and the blood glucose of the mother is important, but it's rarely the problem if they're hypocalcemic or hypoglycemic. However, you certainly can give dextrose or calcium gluconate if you're concerned. Perform a sterile vaginal exam. Having a puppy or kitten caught in the birth canal is quite a common reason for dystocia. You can perform x-rays and or an abdominal ultrasound to check the position, the size, the number of the puppies or kittens, and also potentially, if you have ultrasound, to check the fetal heart rate. If it's non-obstructive, so you cannot feel a puppy or kitten in the birth canal, you can give oxytocin. You can give 2 doses every 30 minutes, again, if it's non-obstructive. If after 2 doses of oxytocin and there are any signs of any maternal toxicity or decrease in those fetal heart rate, you certainly will want to proceed to surgery. Also, if multiple pups remain and the time interval between them increases greater than 2 to 3 hours, that's probably another indication you should move forward with surgery. That said, until you know you're doing surgery, try to avoid any sort of tranquilization or opioids until induction of anesthesia so you don't affect those puppies. In addition to avoiding any sort of tranquilizer or anesthetic agents until the last possible minute, there are other considerations with anesthesia for a dystocia and for surgery. The mother is more sensitive to anesthetic agents. She has a decreased lung volume, decreased functional reserve capacity, and increased oxygen consumption. She'll be more sensitive to inhalant gas. Also remember that any drugs that cross the blood-brain barrier will also cross the blood-placenta barrier as well. So you will want to use propofol or a gas induction rather than some older drugs like thiopental. They've been proven to have decreased neonatal mortality. For the puppies themselves, if you're concerned about a low fetal heart rate, remember that bradycardia in a puppy actually indicates hypoxia. You can try to give atropine. Glyco doesn't cross the fetal placental barrier. But that said, just raising the heart rate isn't necessarily going to help the puppy itself. It's because it's hypoxic. So you may want to give naloxone or epinephrine when that puppy comes out to reverse any of those anesthetic agents. One thing to remember, which is not what I was taught in vet school a few years ago, is we should not give atropine or Doxapram to the puppies once they come out of the womb. Doxapram in particular increases myocardial oxygen demand and doesn't really help stimulate them to breathe. So there are 2 methods of doing a C-section or getting puppies out with a dystocia. One of them is truly what we think of as a C-section. So opening up, incising the body of the uterus and milking the puppies out from each horn into the same incision. Upside of that, of course, is that you don't have to be quite so fast. You're not ligating any blood vessels, so you can take your time to get the puppies out. Also, if this is a planned C-section in a breeding dog or cat, then you'll preserve their ability to have an additional litter. Downside is there is a risk of contamination. So you have to open up the uterus and milk those puppies out. And if there is any infection or any contamination within the uterus, then you're at risk of contaminating the abdomen. Our other method is a spay. Call it an en-bloc ovariohysterectomy. You're doing everything all at once. You have to be fast. Within 60 seconds of clamping the uterine blood supply, those puppies will have lost their oxygen supply. So you definitely need to be quick. But the upside is you're spaying the dog or cat, and there's no need for that uterine incision. Important tips of what you tell the owners when you're doing surgery on a dog or cat with a dystocia. You never promise live puppies or kittens. Although survival rates at birth are around 90%, only about 80% are still alive at 7 days. And of course, if this is an unplanned pregnancy and the owner might not have been as alert to the dystocia as, let's say, a breeder, sometimes the puppies and kittens are not alive. So I do always document the number of puppies or kittens via X-ray, and I'll communicate very clearly with the owners what's going on with those puppies or kittens at the time of surgery. I also tell every client, unless it is a planned breeding, that their patient will be spayed as part of the procedure. Unfortunately, a dog or a cat that undergoes a dystocia once is at quite a high likelihood of having a dystocia in the future, and they could be at much higher risk of having a uterine rupture or another complication that could also risk the life of the mother. Complications with a dystocia surgery are relatively low to the mother. However, anesthetic death, septic abdomen, need for drain placement, infections, dehiscence, and hemorrhage are certainly all things that can happen. Bleeding in particular, since we are removing a very vascular organ very quickly, is something you should probably mention to the owners. I'm not sure you really need me to tell you how to do a regular neuter, but cryptorchid neuters can be quite tricky. The testicle can exist anywhere from the kidney to the scrotum because of the path of the gubernaculum. So sometimes finding a cryptorchid testicle can not be as easy as you think. If you have access to ultrasound or, in a perfect world, a CT scan, that can guide you. But a lot of the time, that's not the case, and surgery is the way you're going to figure out where this testicle is. If it's an inguinal cryptorchid and you can palpate the testicle in the inguinal area, you can make your incision directly over the cryptorchid testicle and do a routine castration. Things get a little bit trickier when there's an abdominal cryptorchid. Sometimes you just don't know exactly where that testicle is, and you want to make sure that you're not removing something that you shouldn't be touching, like the prostate. You'd be surprised how easy it is to mistake one spherical organ for another in that area, and that certainly can happen. So, my recommendation is that you find the prostate, you find the inguinal rings, and the vas deferens. It's a white, shiny tube, and it should really help you differentiate your anatomy. So follow the vas deferens to your testicle and perform an open castration. You can tell owners when they ask, why do I need to do a cryptorchiectomy, that there is a significantly increased risk of cancer in retained testicles, as well as, of course, those male behaviors you might want to avoid and enlarged prostate. Foreign body obstructions are unfortunately something that we see day in, day out in veterinary practice. Dogs and cats love to eat things they shouldn't. Unfortunately, the presentation and the clinical signs for a GI obstruction are very variable, and they can be unremarkable. Very often there's a history of decreased appetite, lethargy, sometimes abdominal pain, sometimes vomiting. That makes things easier, but not always. These are dogs and cats that may be dehydrated, and you may be able to palpate something in their abdomens, or they may be tense on abdominal palpation, but sometimes there's no sign other than just a decreased appetite and not doing right. Another thing you certainly want to do, particularly in cats, if you can, is look under their tongue, because the two most common areas for anchoring of a linear foreign body are under the tongue, again, usually in cats, and at the pylorus, usually in dogs. Just like your physical exam findings, your laboratory findings with an intestinal obstruction or foreign body can also be variable, and sometimes they're unremarkable. Things to watch out for would be a low albumin, elevation in your liver values, just showing inflammation, BUN or creatinine suggestive of a pre-renal azotemia, and particularly the blood gas. Metabolic acidosis with a high obstruction, so they're vomiting all of their stomach contents, all of their acidic stomach contents, will create a metabolic alkalosis, versus a metabolic acidosis can happen if there is vomiting and the obstruction is a little bit lower and they're throwing up that high bicarb fluid from the duodenum. So you can see either side of the coin there. So if those physical exam and blood work findings can be variable, how can you definitively diagnose, or as close to definitively diagnose, a GI obstruction as possible? Certainly, x-rays are a really good place to start. Ultrasound if you have access to ultrasound. We tend to be taught that we should be able to tell every GI obstruction on an x-ray. It's not necessarily the case, but we do have some objective and subjective parameters. On an x-ray, you'll want to look at the size of the small intestine. We've been taught to compare the size of the small intestine to mid-body of L5, that ratio. The paper that this is quoted suggests that a ratio of 2 times the body of L5, the width of the intestine being 2 times that ratio, suggests that an obstruction is very likely. That said, there's always going to be outliers, so use your history and your physical exam findings to help support. Unfortunately, even with something as great as an ultrasound, the agreement between an ultrasound and findings at surgery have found to be only hovering around 64%. So again, I always warn owners that our findings at surgery may be different than what we suspect from our imaging. One of the most stressful decisions you'll make when you have a foreign body or suspected foreign body obstruction is whether the case needs to go to surgery immediately, whether it can wait and go to surgery at another time where things may be more staffed or easier on the patient, or potentially that you might want to wait and see if something passes. For a non-linear foreign body in an otherwise stable patient, you may want to try conservative management, so fluids, not feeding the pet, and rechecking x-rays or an abdominal ultrasound in a few hours. You never want to just send them on their way and see how they're going to do, but have a plan. Say that we need to recheck this pet in 6 hours, 8 hours, 12 hours, whatever it is that is feasible for you and the client. However, if the patient is sick and your degree of concern for the obstruction is very high, then even for a non-linear foreign body, you might want to take this pet to emergency surgery. Linear foreign bodies are essentially always surgical emergencies. There is a study that in cats, about 47% of cats can pass a linear foreign body with a lingual anchor if you cut the anchor under the tongue. Unfortunately, that means that the other 53% of cats did poorly and needed either emergency surgery or unfortunately were put to sleep. So linear foreign bodies, you're going to want to take those cats to surgery. Linear foreign bodies in dogs are even more concerning, that they have an even higher risk of peritonitis than cats, and absolutely you'll want to take those dogs to surgery. So now you've made the decision to go to surgery for a foreign body, and you need to do a gastrotomy. What is the procedure for doing a gastrotomy? Some tips and tricks. Of course, you'll make your midline abdominal incision relatively cranial because your stomach is quite far up towards the rib cage. Isolate the stomach with moistened lap sponges. Removal of the falciform fat can be very, very helpful in your isolation and identification of the structures in this area. Once you've identified and isolated your stomach, place stay sutures in 2 spots in order to assist with your manipulation of the stomach. Then your incision should be in a hypovascular area of the fundus. Hypovascular in order to avoid bleeding when you make your incision, but also to make it easier for you when you're closing your gastrotomy. So you have your stomach packed off with laparotomy sponges, stab incision into the lumen with a scalpel, usually a 15 blade, and then enlarge your incision with Metzenbaum scissors. Be ready with suction at this point because fluid and ingesta may be bubbling out of the stomach and you want to make sure you catch it. Once you've taken out any of that food and fluid, feel the stomach for your foreign body. If you remove your obvious foreign body, continue to feel the esophagus, the fundus, and the pylorus to make sure that you haven't missed any foreign material hiding in any one of those spots. When it comes time to close the stomach, you'll want to close it in a 2-layer pattern. The first layer is appositional, usually a simple continuous pattern. Flush in between those layers. You don't want to trap bacteria in between your 2 layers of closure. And the second layer will be in an inverting pattern. My preference is the Cushing pattern, but a Cushing, a Connell, or a Lambert are all appropriate. Perform more local lavage, change your gloves, lavage the whole abdomen, and then you're ready to close if that's all you have. So let's say that your obstruction is further down in the gastrointestinal tract and you need to perform an enterotomy. Well, first things first, let's see if you can't push that foreign material back up into the stomach and then do a gastrotomy, which we all know is a lot easier than an enterotomy. If you can't and if it's stuck, then the next step is to make your decision about where to perform your enterotomy. Oftentimes, you cannot push that foreign material in one direction or the other, so you have to make an incision either on top of or very close to the obstruction. You'll want to choose the area that looks the healthiest, and that is the aboral segment of the obstruction, so away from that foreign body in an area where it hasn't touched it, so the healthiest part of the gut. You'll milk the chyme, or kind of that liquid ingesta, away from the site with your fingers. And if you have an assistant, that assistant can hold the intestine with their middle finger and index finger. Don't want to use thumbs if you can avoid it, and hold that intestine for you. If you don't have an assistant, you can use Doyen forceps, which are non-crushing, but they can prevent the liquid from coming into your incision site. Or in a pinch, you can use sterilized bobby pins. I don't recommend it, but certainly it's better than nothing if you don't have doyens or an assistant to help you. Once you've occluded and isolated your segment, you're ready to perform your enterotomy. Use a 15 blade. I usually have my 15 blade facing upwards, not down with the sharp portion of the blade. I usually have my blade facing upwards and make a stab incision into the intestine. The reason why I orient my blade like that is that it will cut going in, but if you accidentally push too hard and go to the mesenteric border of the intestine, you won't cut through the mesenteric border. I don't recommend using an 11 blade for this very reason, even though some people do, because if you push too hard, you'll poke a hole in the mesenteric border. So once you've made your stab incision, you can enlarge it with a pair of small Metzenbaum scissors and gently exteriorize and extract your foreign body. Definitely want to have everything packed off and have suction on hold, because even with the best assistant, some ingesta is going to come out, and you want to make sure you don't contaminate your surgical site. Once you've taken the foreign material out, then it's time to flush, do a little local lavage, clean up your area, and close the incision. You'll read about different techniques. I do recommend using a simple interrupted technique with a small size tapered needle and a monofilament absorbable suture. But again, the taper needle and the smallest needle you can find, smallest needle, smallest hole, and do a simple interrupted pattern with 5 or 6 throws on each knot. Some little tips and tricks. You'll read in textbooks that you can do what's called a modified Gamby technique. Really, the purpose of that is to make your closure as appositional as possible. You don't want eversion and the mucosa poking out, but you also don't want inversion that narrows the lumen of the intestine. The modified Gamby is a little bit of a fancy technique just to make your suture come out right at the edge to bring those edges together. I'm here to tell you it's very difficult to do that in a small animal because you don't quite have enough thickness of the intestine. So don't get too caught up on the modified Gamby, but do try to have your needle come out of the intestine as close to the edge and that border of the serosa as possible, while still taking a full thickness bite of the submucosa, which is the holding layer. As you do that, if some of your mucosa everts, there are some other tips and tricks. With each suture, as you tighten it, you can roll it from your previously placed suture and roll it towards your next one, and that will often cause that mucosa to invert. Again, if you're lucky enough to have an assistant, you could also have them use a sterile cotton-tipped applicator as you're tightening your knot to push that mucosa back in. But again, very often you won't have that many hands, and the slowly tightening and rolling technique is one of my favorites. So once you've closed your incision and you make sure that there's no way you could fit hemostats or anything in between your suture bites, then it's time to take some flush and do a leak test. A little bit more research is coming out that maybe a leak test might not be predictive of dehiscence, but personally in my practice, I still do a leak test because I like to be sure. So again, have the edges of your intestine occluded with whatever method you have. Have a very, very small syringe, a 25 gauge needle with, I usually use a 12 cc syringe, and gently infuse saline into your segment of intestine and gently squeeze it to make sure that there's no leakage coming out of it. Before you pull the needle out, allow your assistant or your hemostats to gently open. You don't want to pull the needle out while everything is under a large amount of fluid tension. That could propagate a hole as you pull your needle out. Little tips and tricks, things that I've learned along the way. So now you're happy with your enterotomy closure. Next, local lavage. And then, if you have any concerns about the area, you may want to do an omental wrap or an omental tack. Omental wrap, exactly as it sounds, you take some of the omentum and just wrap it around your enterotomy site. If you're a little bit more concerned about the intestine, but you didn't think it needed to be resected, An omental tack or an omental patch can be very helpful. In this circumstance, you take a nice mobile section of your omentum and suture it in place, 4 corners with that very, very small suture, and a partial thickness bite of the intestine, just serosa, in 4 corners on either side of your incision to make sure that the omentum stays in place. Unfortunately, sometimes the intestine just isn't healthy and you have to resect it. That, of course, is a resection and anastomosis. There are 2 common methods of doing a resection and anastomosis, stapled and hand sutured, but with either one of these methods, the most important part is having a plan. You have to look at the vessels, the vasculature to the intestine, because you need to make sure that where you're making your incision, there's still good blood supply. Super, super important. Then you occlude your ends and you make your cut next to a crushing forceps, right? A hemostat you'll place over the area where you're going to make your cut, make your incision, because you don't want that segment of bowel to leak on you during your procedure. So, atraumatic or non-crushing forceps on the portion of the intestine that you're keeping, and crushing forceps, regular forceps, on the portion that you're about to remove. In order to ligate the blood vessels, you'll have a small suture like a 4/0 monofilament, absorbable, or if you have access to staples or a ligature, that certainly is possible as well. When you're ready to close your resection and anastomosis, again, most of the time in general practice, it will be with suture. Starting with the mesenteric border, because the mesenteric border is the most likely spot for there to be leakage, hardest to see, there's fat, there's blood vessels, sometimes there can be swelling. So place your suture at the mesenteric border first. And then again, my recommendation is to do a simple interrupted suture pattern. Up one side of the intestine, flip it over, and up the other side of the intestine from the mesenteric border. Some people do prefer, particularly if there's any luminal disparity, if one part of the intestine is smaller or larger than the other, to do a mesenteric suture and an anti-mesenteric suture and then fill in on either side. Either one is totally appropriate. Some surgeons, when they have a lot of experience, will close these with 2 continuous lines, up from the mesenteric border and another up from the mesenteric border. Again, my preference is the interrupted, because then if one of your sutures fails, the entire incision line does not fail. If you're lucky enough to have staples, so a TA or a thoraco-abdominal stapler, that certainly is another very good option for resection and anastomosis in larger breed dogs. Small dogs and cats, sometimes the stapler won't fit in there. So that's a lecture for another time. With any GI surgery, one of the most important things you're going to do is communicate with the owner. Communicate about recovery process as well as communicate about risks. The highest risk for any GI surgery, much less so for the stomach, but much higher risk for the intestines, is leakage or dehiscence. The highest risk period of time for that is 3 to 5 days after surgery, 3 to 7 days for the colon. And some of the risk factors for that have been researched quite extensively. Some papers contradict each other a little bit, but in general, what we know are the existence of preoperative peritonitis. So let's say a perforated intestine is certainly a risk factor for leakage following surgery. The presence of a foreign body, not really sure. Some studies say that is a higher risk and others say that it's not. Low albumin is certainly something that has been shown in some studies to be a risk factor for dehiscence, a serum albumin lower than 2.5 grams per deciliter. That generally correlates to just a sicker patient. Same thing with preoperative peritonitis. So use your best judgment. The patients who are more systemically ill will of course be at higher risk of complications. Another thing you'll want to talk to owners about preoperatively as well as postoperatively is the possibility that you don't find an obstruction. Even with the best possible diagnostics, sometimes we go into surgery and either the foreign material has already passed and we can feel it in the colon, or sometimes maybe it was never there to begin with, but there was a functional rather than a mechanical ileus or obstruction. I always warn owners of this. Unless you can literally see a foreign body on a preoperative x-ray, I will always warn owners that the foreign material might have passed or that this might be, again, a functional obstruction. One term that I don't ever use with owners, we can use it amongst ourselves, but I won't ever use this term in my client communication, is negative explore. No explore is negative. Every explore gives you information, and if you don't do a few negative explores, you're probably sitting on too many cases. So you'll always get information. If this is a dog or cat with chronic GI signs, maybe you might want to take biopsies. Maybe you go in there and you find that there's a splenic tumor. Either way, I always tell the owners that if that is the case, this time was not lost and we needed to do this for the health of their pet. So don't feel too bad if you do have some quote unquote negative explores. Just make sure you're appropriately communicating the possibility that that could happen to the clients. One of the most dreaded diagnoses that we can have in a patient, particularly on an emergency basis, is a GDV, or a gastric dilatation and volvulus. These dogs often come in with an obvious bloat. That's why we call it bloat. Their stomach can be very, very distended and tympanic, feel like a drum. Sometimes it's not always that obvious, but very frequently it's quite clear. Other things that you might see in these patients, they might be retching, usually an unproductive retching or a white foam. And then of course the breed and signalment is very important in terms of diagnosing a GDV. Deep-chested dogs, anxious dogs, and what we've found in some research, dogs with a family history of GDV are most at risk. So we see a dog come in, we're pretty sure this is what's going on. How do we want to definitively diagnose a GDV or a gastric dilatation volvulus? X-rays. X-rays are a really, really good way to diagnose. Take your lateral and a right lateral, and the reason for that is you want to be able to know that the pylorus has displaced. The pylorus is in the wrong position. You'll see a double bubble, also known as a Popeye arm. You'll see those two bumps of the stomach where there shouldn't be, and that will usually be a pretty easy diagnosis. Your initial therapy, once you've diagnosed the GDV, most importantly is to get fluids into the patient. Ideally, large bore catheters in the front limbs, because we know that part of the reason why a GDV is so rapidly fetal is that the stomach has enlarged and is compressing a venous return from the hind end. But if you can only get hind end catheters or one forelimb and one hind limb, it's still better than nothing. Get your catheters in and start bolusing fluid as fast as you can. Next step is to decompress the stomach, whichever way possible, an orogastric tube or a trocar. Either one of those is very, very appropriate. If your patient is lucky enough to be awake and feeling a little bit brighter, an orogastric tube might be tricky, so a trocar is just fine. Usually what our emergency doctors will use is a large bore catheter, an 18 gauge, a 16 gauge catheter to trocarize. Make sure you've decompressed the stomach as much as possible, and then you can think about communicating with the owners and potentially taking this patient to surgery. Again, one of the most important steps of surgery is not just the surgery, but your communication with the client. So what do you tell the owner once you've diagnosed a GDV? First things first, a GDV is always a surgical emergency. That said, sometimes if you decompress the stomach, these are dogs that may be able to recover temporarily. That said, over 80% of dogs that have a GDV that has been decompressed and derotated will go on to have another GDV without surgery. So in my mind, again, a GDV is always a surgical emergency. Also discuss with the owners the risks of this diagnosis and the procedure. They can be relatively high. Anesthetic death has to be discussed. Splenectomy. About 16% of dogs with GDV will require a splenectomy because the stomach and the spleen share a blood supply, the short gastrics, and as the stomach flips, it can tear some of the blood supply to the spleen. Also, perforation of the stomach can happen, causing sepsis and peritonitis, as well as a more focal or unperforated gastric necrosis. About 20% of dogs with GDV in some studies show signs of gastric necrosis. That said, sometimes it's not visible at the time of surgery and you do your best, and dogs can develop gastric necrosis postoperatively. Cardiac arrhythmias are quite common. About 50% of GDVs will have cardiac arrhythmias, usually ventricular arrhythmias. Also, they can be anemic. If those blood vessels have torn, there may be bleeding, there may be a hemoabdomen, another thing to keep in mind. So once you have your patient with GDV stable enough for anesthesia, take them into surgery. And of course, you will want to do a full abdominal explore, but before you can do that, you'll derotate the abdomen. You'll read in all these textbooks that you have to derotate counterclockwise. Personally, when it's the middle of the night or in a high stress environment, I don't want to be looking at a clock face and trying to figure out what direction that is. In my mind, I always say, push down with my left hand. If you're standing on the right side of the patient and you push down with your left hand, that's going to be counterclockwise. The twist can be 180 degrees, 360 degrees, sometimes even more than that. Also, they can trick you and go in the other direction. So try my trick with the push down with your left hand, up with your right hand, but if things don't seem to be going in the right direction, you might have one of those weird ones that's twisted in the opposite direction. Then, of course, evaluate your spleen. Feel the pulses to the spleen, and if you need to, perform a splenectomy. Again, if you need to perform a gastric resection, do that as well. Close it similarly to the way we discussed gastrotomy in 2 layers. The last step, which is extremely important, is the gastropexy. The most common type of gastropexy is the incisional gastropexy, where you make an incision about 3 or 4 centimeters long, partial thickness, through the muscularis, but not through the mucosa of the stomach, and a corresponding incision through the muscle in the body wall, and suture in 2 suture lines, the stomach to the body wall. There are other types of gastropexy, including a belt loop, a circumcostal, and laparoscopy assisted, and also tube pexy. Those are the less common forms. One way you're not going to want to do a gastropexy is an incorporational gastropexy. In that circumstance, what you're doing is you're taking the stomach and you're suturing it directly to the body wall. You do not want to do that because, God forbid, the pet needs another surgery. The next surgeon is going to be going right into the stomach. And of course, the most important part of the surgery is the gastropexy. What are the different types of gastropexy? The most common type of gastropexy, and the one that I recommend, is the incisional gastropexy. An incision about 3 to 4 centimeters into the stomach, about 3 to 4 centimeters away from the pylorus. It's a partial thickness incision through the muscularis, but not through the mucosa, with a corresponding incision in the body wall. Suture those together in 2 lines, starting with the deeper one, really hard if you start with a more superficial line. And that's your incisional gastropexy. The other types of gastropexy, less common, include belt loop, circumcostal, and tube assisted. So if you put in a gastrostomy tube, that will be a gastropexy, as well as lap assisted or fully laparoscopic. One type of gastropexy you do not want to perform is an incorporational gastropexy. And in that type, what happens is you suture the stomach directly to your midline incision. And the reason why that's not a good idea is, God forbid the dog ever needs another surgery, the next surgeon making their midline incision may end up directly into the stomach. Going back to our conversation with the owner, what are the risks and what's the prognosis of a dog with a GDV? Mortality rate is about 20 to 45% in treated animals, a really broad range depending on what paper you read. Their presentation has a lot to do with their prognosis. Lactate numbers as well. If they have a very high lactate on presentation, poorer prognosis. If their lactate doesn't respond to your initial stabilization, IV fluids and derotation, decompression of the stomach, that's also a negative prognostic indicator. Dogs with gastric necrosis are unfortunately 11 times more likely to die than dogs without gastric necrosis. Recurrence, owners will certainly ask about that. the recurrence rate of a GDV with gastropexy is vanishingly low, close to 0% with an incisional gastropexy, and low with other types of gastropexy. Things that can still happen are bloat. No flip, but the stomach can still become dilated, and they can still have some GI upset and chronic GI disturbance even with a gastropexy. An additional consideration with a GDV is, if a patient has had a splenectomy in the past, could that place them at higher risk for a GDV? We're not sure. There's one research study that says yes, and there's one that says probably not. So I look at my patient population. If I'm doing a splenectomy in a dog who's at very high risk, first degree relative, breed, size, anxious dog, then I will recommend a gastropexy at the time of splenectomy. Again, this is up to the owner. I always present it as an option because we don't 100% know how much higher that risk becomes with splenectomy. Now, not everyone will feel comfortable doing an amputation in general practice, but sometimes you have no options, or that's something that you do want to get good at and get more practice. Things to keep in mind: contraindications to amputation. The true contraindications are neurological disease or severe enough osteoarthritis that a pet really isn't going to be able to get around on 3 legs. There are some incredibly motivated owners that even with those contraindications, they may be willing to get some sort of cart or trolley or harness. So even something that we think of as a complete contraindication may be a relative contraindication, but absolutely want to have those conversations about mobility with those clients. In general, prior to performing an amputation, you'll want to do a full workup. Of course, if the reason for the amputation is trauma, the patient may be a young, otherwise healthy dog or cat with no other comorbidities. But majority of the time for an amputation, we are talking about cancer. So the minimum database for a workup for an amputation would include blood work, CBC Chem UA, chest radiographs, plus or minus ideally an abdominal ultrasound, just to make sure there's no sign of movement or spread of disease or metastasis. Most likely reason for a bone tumor, of course, being osteosarcoma. Very frequently, a radiologist will feel comfortable calling it as an aggressive bone tumor, and a biopsy or an FNA isn't always indicated, but there are a lot of owners who will want a diagnosis prior to forming an amputation, so a fine needle aspirate or a bone biopsy may be indicated. For the forelimb, the most common type of amputation that we perform, and the one that I recommend, is a scapulectomy, or a 4-quarter amputation, in which you remove the entire forelimb, including the scapula. Quite frankly, it's a lot easier than a disarticulation, and also you're not leaving that scapula behind to have a bony prominence if there's any muscle atrophy or other reasons why that bone might be a cause for sores. For a hind limb amputation, similarly, I recommend coxofemoral disarticulation, so removing the whole limb from the hip joint down. Mid-femoral amputation can be performed, but again, it's a bony prominence, and with muscle atrophy, that can be a source of sores. Important things to keep in mind are nerve blocks and knowing your anatomy. Definitely want to block with bupivacaine all of those nerves prior to transection to try to decrease wind-up pain and potential for neuromas. Very good prognosis for function in most pets. Sometimes even those pets where you think that an amputation might be really hard for them to recover from, they're walking around on 3 legs even a day after surgery. I had one patient where there was a cat who already only had 3 legs and due to trauma needed a forelimb amputation. She had radial nerve dysfunction and was actually trying to traumatize her own foot. And I counseled the owners that I wasn't sure that amputation was the right choice. This kitten is jumping and walking and climbing on cat trees and doing everything she wants to with only 2 legs. So our patients are amazing and we're very lucky to have them. Mass removals, very, very common type of surgery that you're going to have to do, but equally important to have a plan and to make sure that you know you're going to get appropriate margins and you're doing the right type of surgery for the diagnosis. So look up the tumor type. Diagnose the tumor type, whether by fine needle aspirate or by biopsy. This is one circumstance where it's extremely important to know what you're dealing with in order to make your surgical plan. So, you have your diagnosis. Look up the tumor type and the recommended margins, both laterally, call those metric margins by the metric system, as well as deep margins, better known as biological margins, meaning the tissue that you need to get deep to the mass to get all of those tumor cells. So once you have your plan and you know your tumor type, look at the patient. Look at lines of tension. You can look up lines of tension in a textbook as well to make sure that you're orienting your incision in the correct direction. Then mark your margins. You'll want to use a sterile marking pen and a ruler to make sure that you're going your adequate margins around the tumor. Next, deep margins. Usually that's muscle fascia. You want to see that white, shiny muscle fascia lining and remove that as your deep margin. Once you have your tumor out, give everything a good flush, change your gloves, and mark your margins with hemoclips if you have them, if available, because God forbid there are leftover tumor cells and radiation therapy may be an option, those hemoclips will be your markers. Again, if the client is not going to be interested in performing radiation therapy, those hemoclip markers become less important. Also, planning your closure before you make your first cut. Those big margins can lead to a really big defect, so make sure beforehand that you've brought that skin together and you know things are going to be able to close. Also, think about tension relieving patterns. Ideally, you shouldn't have a lot of tension, but look up those tension relieving patterns just in case. Again, remember, with every surgical procedure, there's the surgery as you want it to go, and then there's the surgery the way life throws it at you. So you better be ready for those contingency plans. Other than that, also discussing postoperative care with the owners, making sure that they're aware that even with the best margins, you can still sometimes leave microscopic tumor cells behind, so follow-up therapy may be necessary. Last but not least, our last topic for this segment is an oral hematoma. These might seem relatively simple, but there are tips and tricks to make your life easier with oral hematomas. Ideally, making an S-shaped incision, not a linear incision, but one with a little bit of a curve to it so that those edges don't seal back together too rapidly. Make your S-shaped incision, flush all of the clots out with sterile saline, and then place multiple mattress sutures, oriented vertically, not horizontally. You don't want to cut off the blood supply to the ear. Oriented vertically, and the size of the suture will depend on the size of the pet. So usually a 2-aught or a 3-aught monofilament non-absorbable suture. Take those full thickness bites all the way through the ear and all the way back. A lot easier to use a straight needle on this, but sometimes you can use a curved needle as well, totally fine. Keep about a 5 millimeter separation between those sutures. Common mistakes. Not going close enough to the edge of your incision line so those edges are able to kind of curl up and not seal down. Another common mistake is not having your sutures extend over the entire pinna. If you just address the hematoma in one area, but let's say the dog still has an ear infection and they keep on shaking their head, they might develop a hematoma in another part of the pinna. So I always distribute my sutures kind of throughout the pinna, even if my hematoma is relatively small. Things to talk about with the owner. Again, even though these seem like relatively simple surgeries, no surgery is routine, and there are complications that may happen. Recurrence, infection, and complications with healing. They also have to be reminded that if you don't treat the underlying ear infection and the allergies that got you there, they may very well end up with another oral hematoma. So that's all we've got for surgery and general practice. Next up, the orthopedic exam.